everyone. Thank you so much for the opportunity to present today. My name is Pooja. I'm one of the fourth-year plastic surgery residents, and today I will be discussing our work on cost-effective care for massive burns, a Markov analysis of cultured epidermal autografts versus suspension autografts. The authors have no relevant disclosures. Massive burn injuries, or burns to more than 50% of total body surface area, remain some of the most expensive and complex types of trauma that hospital systems encounter. While overall survival after these massive burn injuries has significantly improved over the years, in-hospital mortality remains higher than 50% in many centers. Furthermore, just in the acute phase of burn treatment, these patients often need more than 5 major surgeries, with the cost of each surgery in the hundreds of thousands of dollars, and the overall hospitalization costing in the millions. There are a number of unique treatment challenges associated with massive burn injury that make these cases particularly difficult and expensive to treat. First, there is limited to no donor skin available. Second, there's often systemic injury and concomitant polytrauma. These two factors directly challenge the common paradigm of early excision and grafting, and which further complicates these patients' prognoses given the known correlation between % open of TBSA and mortality risk. Luckily, skin expansion technologies have revolutionized the ability to treat these massive burn injuries by allowing for wound closure despite limited donor skin. Traditionally, we have used cultured epithelial autografts, or CEAs, which are confluent sheets of epithelial cells. These grafts are generated using a small sample of keratinocytes from unburned skin, which is expanded in vitro in a lab in Boston. While this technology is older and more established, it does require a 3-week production period off-site and costs nearly $10,000 for 200 square centimeters. Widespread use of CEAs has been limited, therefore, by the difficulty in manufacturing these grafts, the variable take, and high costs, which has prompted the creation of multiple competing products over the years. A newer option that has been available in the last 5 years in the US market are suspension autografts. Healthy keratinocytes are digested with trypsin in the operating room itself and expanded into suspension, which is then sprayed onto the wound bed. This is a point-of-care solution that has half the cost of CEAs, but its clinical efficacy is not as well established. This begs the question of whether this newer product is cost-effective compared to the more widely used CEAs, an important consideration for these expensive injuries. As such, the objective of our study was to investigate the relative cost-effectiveness of confluent CEAs versus cell suspension autografts for the treatment of massive partial thickness burn injuries. This is a first-of-its-kind study investigating cost-effectiveness in the setting of massive burns. These are some of the most expensive injuries that we see here in the hospital, and reimbursement is variable, especially with Medicaid patients. Through the study, we therefore hope to optimize cost of care without compromising clinical quality. We performed a cost-effectiveness analysis comparing CEAs versus spray keratinocytes in adults with massive burn injuries. Direct costs of care were calculated using Medicare reimbursement and manufacturing data, and indirect costs in terms of productivity lost were calculated using the 2024 US hourly wage statistics. Effectiveness was determined using the Vancouver SCAR scale as a proxy for quality-adjusted life years. 10,000 patients entered the model one at a time using Monte Carlo microsimulation trials and received either CEAs or cell suspension autografts. They then cycled through the Markov states across the duration of the model time horizon, including successful wound closure, complications requiring reoperation, and graft failure. Study data were derived from randomized clinical trials and cohort investigations of CEAs and cell suspension autografts in comparison to standard of care, which is traditional skin grafting. Ultimately, CEAs achieved successful wound closure in 73% of patients, while suspension autografts achieved wound closure in 68% of patients using pooled data from the literature. In the base case of the model, suspension autografts were found to have both direct and indirect cost savings, with a direct cost savings of almost $255,000. Furthermore, model results demonstrated no significant change in the overall effectiveness compared to CEAs, and as such, suspension autografts were found to be the dominant strategy. In other words, at a standard US willingness to pay threshold of $50,000 per quality unit gained, CEAs would have to clinically outperform suspension autografts at a rate of 4x to be considered cost-effective. While wound closure was slightly higher in the CEA group, the difference between the two treatments in terms of ultimate scar outcomes was not significant enough to warrant the extra costs associated with the CEA modality. These findings were robust upon both probabilistic and deterministic sensitivity analyses. Ultimately, therefore, we determined that suspension autografting is the dominant strategy for the treatment of massive burns, with relatively similar effectiveness as CEAs, with substantial decrease in costs across both the health systems and societal perspectives. Suspension autografts represent an important paradigm shift in massive burn care by providing a point-of-care solution for wound closure. We identified three major areas in which suspension autografts reduce costs compared to CEAs. First, there's no external processing or specialized facilities needed. Second, there's a faster time to initial grafting. And third, there's an overall shorter length of stay. As a point-of-care treatment, suspension autografts can be prepared immediately in-house and applied to wound beds. Furthermore, by expediting the grafting and recovery process, suspension autografts not only reduce costs, but could also ease strain on burn units. The study was not without limitation. Data were derived from existing limited literature, and quality of life outcomes were estimated from the Vancouver scale. As such, our next steps include larger scale work investigating outcomes of suspension autografts. Suspension autografts can be somewhat user dependent in terms of technique and processing and application, and as such, it is important to evaluate their efficacy across centers. It'll also be important to gather more longitudinal data on the suspension autografts, as ultimate costs of burn care extend beyond the initial acute phase care and also depend on the longitudinal scar management. Thank you so much to the Stanford Division of Plastic Surgery and the Department of Surgery for allowing us to share our work today. And a special thanks to the Santa Clara Valley Burn Center and to all the patients who entrust us with their care. Thank you.